Welcome, everyone. Thank you so much for joining. Really, really excited to have you be part of this Workplace Safety Strategies webinar. Our goal today is very, very simple. We want for you to walk away feeling more empowered about how you can elevate the culture of safety within your organization. And more importantly, we want to leave you with one action, something that you can take away and implement right away so that you can have that meaningful impact. You're going to hear really unique perspectives today. You're going to hear from Darcy, who is a practitioner in the industry, who's made safety a cornerstone of her work. You're going to hear from Dave, who's a workplace violence expert, who is a published author and consultant that works with organizations to help them mitigate risk. And then you're also going to hear from myself, a technologist who has developed safety tools designed to protect at-risk staff. One thing to remember is we're all here because we want to elevate the culture of safety within our organizations. We're here for a united purpose and would love for this community to be a safe place where we can share our ideas, our thoughts, and really get your engagement throughout this webinar. So feel free to share your thoughts. If something particularly resonates that Darcy and David share in the chat, feel free to comment. And then we do have a Q&A section as well. So feel free to also pop in there, and we'll keep an eye out for it during this discussion. With that, let's jump right in for the second time. I'd love for each of us to go around and talk a little bit more about what we do and answer the question in particular of why workplace safety is important to you. Darcy, why don't you kick us off?
Hi, everybody. I'm Darcy Lichnerowicz. I am the CEO at Southcoast Behavioral Health, which is a freestanding psychiatric hospital in Dartmouth, Massachusetts. And in healthcare, we're talking a lot more about safety these days. And I've worked as a clinician for many years, and I've worked in administration now for many years. And so this is something that's a really high priority for us. I think it's really important that as I look at the team that I work with every day and that I really care about personally, I want to make sure that they feel like we're all working well together and that the work that they're able to do is able to be done in a safe and secure way, and that the patients that then come through our doors also have that same experience so that we're all working together toward that same goal of getting people well in a space where people feel they can do that safely. So it's really exciting to be part of this conversation and looking forward to talking with the group.
Fantastic.
And I'm Dave Corbin. Oh, sorry. And I'm Dave Corbin. I am the owner and principal consultant for Dynamic Security Strategies, a security consulting firm that focuses on healthcare and workplace violence prevention and mitigation. And the reason I feel like this work is so important to me and so important to our community is because I don't feel like any caregiver, anybody who works in the healthcare environment should fear for their safety every day when they come to work. And it's important that we realize in many cases that's what's happening. And that's why I have dedicated my work and my focus towards workplace violence for many years, both as a practitioner and now as a consultant, because nobody should be coming to work like that. And they can't give the best patient care if they're worried constantly about their safety. And we have a very unique situation in healthcare where we make up a small percentage of the overall workforce in this country, but have the highest rate of non-fatal assaults.
Wow, Dave, thank you. And I'm Yasmine Mustafa, CEO and co-founder of ROAR. We help protect at-risk workers. And I'm really passionate about this topic because I was an at-risk worker and at the time didn't have the power to do anything about it. And then once I did, I decided to start a company to help others not feel the way that I did. And so thank you all for that sharing and having folks just learn a little bit about who you are. Because there's so many leaders, some familiar, some I'm not familiar, that I see here in the attendees, could each of you talk about why it's really important for these leaders to show their staff that they're engaged and really helping set the tone of safety within their workplace?
Start with that. I think, when I think back on when I was a young clinician to where things are at now, this is a conversation that is a lot more frequent to be having. When I was a young therapist, I would never have gone to an interview and asked, tell me about your safety protocols, tell me about your training. But it's something people are asking about now because people want to know where they're going to be working, has a good plan. There's always been kind of the conversation about, we know that when we do these jobs, there is some inherent risk, but we also know that there's a lot of tools that can be put in place, and people want to know that you're taking this seriously. So even in interviews that we're having with people, and when we're bringing folks on board, it's part of some of the early conversations we have to kind of set the tone that these are things that we're talking about. These are things that we're looking at because we want to make sure folks understand what they're going to be working with, and that they know how important it is from the top down, from the CEO, from nursing leadership, from whomever, all the way down, and that trickles down through every level. And it's not something that they're going to get on board and then feel like they're on their own.
Spot on. It's always from the top down. Yeah. Thank you. What about you, Dave?
I would echo what Darcy said, and in particular, my stance has always been that you cannot truly have an effective workplace violence prevention and mitigation program if you don't have the visible and consistent support from the top. And I like to see the whole C-suite engaged. I like to see absolutely the CEO engaged at the top. I've seen some organizations where the CEO has come out and been very vocal about their support, not only in their own organization, but outside of their organization with the media, and letting them know, like, hey, I'm behind this 100%. The other thing I think is important at the C-suite level is to have a champion assigned to the workplace violence effort. Sometimes that's the CNO, sometimes the COO, CMO sometimes, but you need somebody who's going to be the champion, because it's great when the C-suite is engaged. But I really like to see somebody who's like, okay, this is my baby. I'm going to run with this and make sure I am lockstep with what's happening in the rest of the hospital. And you can't get the resources you need. You can't get the support you need if the C-suite's not engaged. And just like you said, Yasmine, it starts at the top, and Darcy, and that's absolutely critical at the very start of your program, or if you're halfway down the road or you have a program and they're not engaged. That's a huge gap that needs to be addressed, like, right away.
I love it when I talk to CEOs who, this is something that they're behind 100% and championing it within the organization, and especially getting out and talking about it publicly, because if safety feels like this taboo topic that shouldn't be discussed or talked about, when, if anything, it should be discussed even more based on the world that we're living in today. Let's dig into a little bit of standards, mandates. This has actually been a hot topic that comes up a lot in conversations that I have with customers and prospects. Dave, you, I know, have been on top of keeping up to date with the upcoming OSHA standards. Can you talk about them a little bit and what people should expect?
Sure. I haven't had a sneak peek at the OSHA standards, but I am basing this on what I know from the previous OSHA guidelines that they had put out, through their workplace violence educational materials, and through looking at a lot of the laws that have been passed across the country in the absence of federal legislation, federal laws, and OSHA enforcement, specific enforcement. They have been doing enforcement in healthcare. But really, I've seen sort of a pattern with these laws that have been passed around workplace violence in healthcare. And the first one is, and some of these are boring. You're going to say, Dave, we have this and it's great, but I think they have to do this because some folks don't have the basics in place. So the first one is making sure that they put together a workplace violence prevention plan, right? But they want you to do that with a multidisciplinary team, and they want you to involve line staff. And I'm not saying OSHA here, okay? I'm saying this is what I think may come from OSHA based on what all of these other states are doing. Especially California has very strong laws that have been around for a long time around healthcare. And but if you look at all these laws, they all have these commonalities. So that's what I'm talking about. So they want that multidisciplinary approach. They want line staff involvement in that. They want training for your staff. And in most cases, they want it to be based on risk. right? Risk and role-based training, not just everybody gets 1 hour of training, check the box, you're done. But they want to make sure, hey, frontline clinicians should have a higher level of training. Security should have a higher level of training. You know, your reception desk staff needs some level of training. So they don't just want check the box training. They want you to do risk and role based. They also want to make sure that you have a plan for responding to workplace violence emergencies, meaning when there is a whatever you call it in your hospital, a code gray, code whatever, that when you have a security emergency, that there is somebody there, that there is some sort of plan in place as to how that's handled and at different levels and who responds and all that good stuff. They also want to make sure that you are obviously identifying environmental risk factors with your patients and other people who are in your healthcare setting. So they want you to kind of be monitoring that on a regular basis, but also doing like an annual security and violence risk assessment in your hospital. They like the ongoing version, but it's also, I've seen a lot that want you to do kind of pull that into your hazard rounds that you're doing. And there's always a reporting out piece that they either want you to report out to the state or they want you to keep a log and submit it on with some kind of cadence. I don't know if OSHA is going to require that, but I worry about that personally because I worry about people hesitating to report incidents that are happening in their organization for fear of repercussions from OSHA or looking bad or whatever. I think it's a good thing for accountability, but I worry about the effect that it might have, the silencing effect it might have on some organizations. I mean, that's generally what I see commonality-wise. I mean, I can keep going on and on, but I know we have other topics. And I think the OSHA, what you going to see from OSHA is going to be close to what you see in these other states that they're passing, because they're all kind of following each other.
That's a lot, Dave. That's overwhelming, but also seems like very common practices that should be in place. So thank you for sharing that. Darcy, on the flip side, you run a facility and there are mandates that you have had to follow and have to follow as within the type of facility that you have. Can you talk about where you are, what kind of facility it is, where you are, and then any mandates that you've had to make sure that you abide by and any insights to share with folks?
Sure, just real high level. We're in Massachusetts, and so we have local regulators who have requirements around this. We lots of hospitals, I'm sure many of you know, you have your Joint Commission standards, and there's definitely been increased guidance and support from Joint Commission and other accrediting bodies around exactly what David just talked about, whether it's having your risk assessment, it's having your trainings, it's having your committees and what those should consist of. So there's a lot of different entities who are really focusing on this as a topic, whether it's in surveys or just providing additional tools and resources to help facilities make sure that this is prioritized with a regular cadence. So that's been a lot of what we've been able to draw from our the Department of Mental Health and Joint Commission and OSHA and lots of these different bodies who help ensure that we're meeting all of the standards we should and incorporating those into our daily processes, into our policies, and making sure that all of those, because each of them has very common themes, but then some of them are a little bit more specific. So we spend quite a bit of time just making sure that we're up to speed on changes, maintaining good relationships with those regulators so we can call and consult with them, and then just making sure that we're trying to stay ahead of what is coming so that we're proactive versus reactive.
Love that. Thank you. Thank you for sharing that. I did promise folks that they're going to walk away with a tangible item they can take back to their organizations. And I'd love to pivot a little bit here and dig more into the critical elements that should be in place for a safer workplace. If you were to share your top 3 foundational elements for workplace safety, what would they be? And David, why don't we start with you?
Sure. So one of them I already gave away. I'm sorry, but that was the C-suite support. That's my number one. After that is one accountable leader. Anybody who follows me on LinkedIn is gonna be like, Dave, you keep beating this drum, but you need one accountable leader for your workplace violence program. That's what Joint Commission wants now. They don't get too specific on how that works. But in my mind, the ideal situation is you have a full-time person in a director role who has a good, strong clinical background. And they don't have to be a nurse. They could be, I know some of the folks that are running some of the best programs out there are, workplace violence programs are coming from like addictions counseling and recovery background and like social work background, behavioral health. So having somebody with a clinical background, and if you look across, the country, you'll see all different versions of this, right? I've seen everything from like almost like a medical level person, almost like a doctor level person running the program, all the way to, a security somebody with a security background. And oftentimes I see it's a security background. And I think that can be effective too. But ultimately, about 90% of all the violence is happening from patients. And if you don't have somebody with a clinical background that can talk the talk with the folks who are doing the work every day and understand the clinical roots of this problem, then it's, that person cannot be as effective, in my opinion. And then, after having the people part kind of checked off, you have the C-suite, you have your one accountable leader. I think that training is the next biggest thing because you're empowering staff, right? And the way I look at it is, okay, if the only training you can do is online, that's good, not great. Okay, the better version is in person. Okay, I was just doing a risk assessment today, and I heard these folks say, yeah, I did the online training, but I'm going to a 4-hour training next week, and I'm really excited about that because I've heard really good things about it, right? They're going to be there for 4 hours. They're going to learn. And these folks are coming from like an ambulatory, community care site. So they're going to get some excellent training alongside their colleagues. So in person is great. And then to take it to the next level, to do simulation training if you can. And that is a luxury, I know, in many places. But to put people in a simulated environment, some people are using VR, not as many, but using actual simulations in a sim lab with trained people that can simulate different scenarios with them in a safe and controlled place. So they can practice, because you get these techniques and then you go back to work and you might not use them if you're not in a high-risk unit. So having a chance to practice in a safe place kind of really drives home those lessons. So those would be my top 3.
Thank you, Dave. How about you, Darcy?
From my perspective, I always think like a clinician still. And when you're a clinician, you start with an assessment, right? You start with gathering your information and you find out what is the lay of the land that I'm looking at here. And you try to gain that information from as many points of information as you can. So I think the assessment piece is critical to really understanding what your strengths are, where you do have some good things in place, or where your pockets of opportunity and risk might be. So pulling that information from as many places as you can, again, to something I think, David, you said it earlier, from line staff, from the people who really know, right? Like, I think I know a lot. I like to think I know a lot, but the reality is I'm not in every single job in my building. We need to find out from the people who are really doing these roles what their experience is and what their perspective is. And so pulling folks together who are really in the know in every different seat in the building is helpful. And we have a building, right? I have a hospital here, but then of course, if you've got other services, thinking about all the different places that your folks are is important. So whether you've got people doing transportation or outpatient or home visits, things like that, talking to the people who really are the experts in their jobs and what they're encountering every day is going to make your assessment just that much more viable if you're really trying to make some positive movement with it. So that's always my starting point. The second piece is embedding it throughout your entire organization. Just because it exists and people know that a thing exists doesn't necessarily mean that it's been incorporated. So finding different places to keep sharing common language, sharing the information, especially as things change, making sure people have access to those changes and that it stays top of mind is really important, because everybody gets so busy and people are all doing different jobs. And, we think that it's sometimes one and done communication, but it's not. We have to keep it a vibrant part of what we're doing every day in whatever touch points we can. And then the third thing that I think is really important is it's not just necessarily about engineering solutions or policies or things. It's also about, in healthcare particularly, it's about the relationships we have with our patients. When we know that patient violence is one of the main points where there are injuries and risk, I think I heard a great guy speak not too long ago, a colleague who is actually in healthcare security. And this guy he's like 6'4", he's got the uniform, he's got the taser, he's got the badge, right? He's exactly what you think of when you think of security. And what he said is the most important tool that he has are his ears, and that he has found that he has been able to de-escalate and deal with unsafe situations far more effectively just by being attuned to what was being said or what an unmet need was, and to being able to build rapport with that person versus going into full force, a restraint or some kind of physical interaction. And I think remembering that we're dealing with humans is so important to the work that we do in healthcare. Our staff are humans. We come with our own stuff. We come with our own, tough days or histories. So that's one piece. But then that rapport that we can build with our patients, if we listen to what they're telling us, if we watch for opportunities to meet needs before they become problems, I think that is something that we never want to lose focus on, because that's a huge piece to maintaining safety in our facilities.
I love it. Thank you. Absolutely. Yeah, I'd love to switch it up and talk about pitfalls too. And I do want to reinforce a couple of things that you both said that we see from the technology side, that if it's not there, the staff isn't going to be as engaged. And it's repeating back, Dave, what you've said a couple of times, and Darcy, you mentioned it too, is if leadership isn't engaged, everything falls apart. If no one owns it from the top, it's not gonna be implemented or done. We've also seen that there has to be one person responsible for the implementation and for the to be accountable for the system. Because when there's two people accountable or more than one person, what do they say? No one's accountable. And that's also something that has been really, really important. And then one thing I think people get surprised by is reporting is a good thing. That's why the system's being implemented. And for us in particular, one thing we do make sure that we reinforce is that it's going to increase, and it should increase. And if it's not increasing, the staff don't feel safe to report. And of course, that's really, really critical. So just making sure that, especially when you're implementing a new system or a new process, being able to call out the people doing it well publicly in front of others, so that it models the behavior that you want to see in the other staff as well. But yeah, so these are the takeaways. We focus a little bit on that. What about what people shouldn't take away, or what about common pitfalls that folks might fall into as they're getting started, or continuing, of course, to reinforce safety within their organization? Dave, why don't we start with you?
Sure. And just to kind of piggyback on what you just said, the whole piece about reporting, that's one of the pitfalls, is people encourage reporting. I'm like, oh my God, there's, 100 more reports this month, and that's bad. It's like, no, like you have to message that up front, because that's definitely an issue. The other thing that I find as a common pitfall is over-reliance on technology, right? So when I say that, I don't mean as part of a layered approach, as part of a, people-driven, programmatic approach. I mean, when somebody buys something and they're like, okay, once we do this, we're good, and this is going to solve our problem. One of the things that comes to mind is metal detectors. It's like, okay, we don't have a workplace violence program per se. It's not that strong, but we just put in metal detectors so nobody can bring in weapons. It's completely impossible. And, now we're safe. And I find that that's often not done consistently at all the entrances, and some of the technology out there isn't as great. There's a lot of chances for human error. There's, so I think that metal detectors can be or weapons detectors can be very helpful, but as long as you have all your other core stuff done first, like focus on your program, focus on the core things that need to be in place first. Another thing that comes to mind is body-worn cameras. People are like, oh, body-worn cameras prevent violence. It's like, no, they record violence, right? I have not seen a study yet that is not sponsored by a company that sells body-worn cameras that says that they actually reduce violence. They have other benefits, right? They can help protect staff against, frivolous complaints. They can help validate a complaint that a patient made or something like that. They can provide very good evidence in a situation where something happened. But I have not seen anything that says they can prevent violence. So I think, those are a couple of the pitfalls, and just over-reliance on violence, over-reliance on technology in the absence of the other programmatic elements, I think, can lead to a false sense of security and focusing on the wrong thing.
Thank you, Dave. How about you, Darcy?
I think one of the dangers in developing a workplace violence program or looking at your risk is that we look at this as potentially as a task to be completed, and a box to be checked, and something that has time frames that we have to redo these things. But if we look at it as a task versus a way of operating together as a team, and something that has a place in a variety of different areas in what we do, I think that makes it far more effective. Timeframes are sometimes arbitrarily assigned, a once a year training or a once a year review, quarterly committee meetings. Those may be what we have as a cadence, but at the same time, if it doesn't always make sense, there's nothing that stops us from doing it more frequently or from doing it differently. So I think when this becomes something that is a box to be checked, then we miss opportunities. But if we try to embed it as part of the language that we speak every day, that can make it a lot more of an actual program versus being just some isolated committee that has a binder somewhere.
100%. I think for us, what we see is people think this training is one and done, and it has to keep staff has to retrain, and of course, enforcing using the tools correctly and the procedures is just as important as well. Let's pivot a little bit, because I know one of the things we talked about in what we're going to cover today is the balance between long-term strategy, planning ahead, thinking through a full program, and also short-term wins. What are some of the differences of both, and what would you advise the group that's in this webinar?
I would say that if you're just starting your program, or if you're trying to strengthen it or evaluate it, that you focus on, first of all, just building a strategy, right? And prioritizing the things you can get done. When I do an assessment, oftentimes I find that the things I'm recommending are low or no cost in terms of dollars, but they might require a larger time investment and resources, human, resources within the organization. But your strategy should be what you're using to drive your tactical piece, right? To make sure that it's in alignment with what you're trying to achieve. Otherwise, it's very easy to get caught up in the day-to-day. If you work in a very busy hospital with an emergency department, a large academic medical center somewhere, or even some community hospitals, behavioral health hospitals, the tempo of those hospitals, the operational tempo can be extremely, fast. And there's always something happening, and there's always the next sort of threat to chase and the thing that you're worried about. And you don't want those things to drive your program. Like, let's react to the last thing that just happened. Okay, somebody just found a gun on somebody in the ED. Now we need weapons detectors. Let's spend, $400,000 and get those weapons detectors. It's like, okay, pause for a second. Let's look back at our strategy. Where are we with our strategy? How can we address this? And the one thing that I have found is, if you can keep your eye on the prize and build that strategy and fill it out, as you go through with those tactics and keep on that strategy, that will help you when those things do happen, right? Because you'll have a very good program, a robust program that can stand up and help get you through and make you a more resilient organization when something bad happens. And there are going to be seriously violent events despite your best efforts. Okay. So having a really strong strategy and staying with it will help you build that rock solid program that will help you when bad things happen and keep you from getting dragged, in a certain direction because one thing happened. Tactically, I think that some of the best things you can do are, just making sure that you're following up with staff when they make a report, that you follow up with them consistently in a very timely way. Check in with them. Some staff gets injured, check in with them, offer them safety planning, offer them EAP resources, follow up with them, and keep tabs on them, and follow up on reports. Staff are going to not keep reporting things if nobody ever comes to check on them. And I have seen so many times in hospitals that I've done risk assessments, and where I talk to people and they're like, I'll say, oh, they tell me something bad that happened. Did you report it? No, I didn't. No, why? Why didn't you report it? Oh, why should I bother? Nothing ever changes around here anyways. Okay. And that was the attitude, right? And that was the attitude among other staff. So follow-up doesn't cost anything. Again, it costs time, but it means a lot to staff to know that you're following up, whether they've been injured or whether it was a near miss, whether it's an environmental hazard that could lead to workplace violence or security issue. It goes a long way.
Thank you.
Piggybacking a little off of that, David, once you have that strategy and you've implemented it, making sure that what you've intended to do is actually working and happening. The risk too is that just because we've implemented a strategy doesn't mean that it keeps momentum. People do get busy, especially, Dave named off a bazillion different places that it just run like crazy all day long. And that is the danger too. Just because we've rolled it out doesn't mean it has maintained that momentum and that it's become embedded. We have to build muscle memory. We have to build automatic reactions. And, you can do those things in the short term by we do a lot of drills, right? Like do mini practice sessions, do micro learning sessions. I think keeping it alive in every space that you can possibly embed it in, whether you've got rounds or treatment team meetings, things like that. There are lots of places to incorporate it very naturally that don't cost a ton of money or any money at all. You can do a drill and have a box of candy bars and people get excited about that, right? but building that muscle memory and building that team response so that people kind of kick into autopilot when something occurs is something that is really very beneficial to making sure that whatever your strategy was that you built actually then takes effect and is sustained. And if it doesn't, then it does give you the chance to reevaluate and pivot, because if it's not working, we don't want to keep doing the same thing and believing our own hype that it's working, right? So by keeping those sessions going, by engaging in practice and drills and mock situations with folks, it also gives the chance for that dialogue to continue with people who are doing the work every day to say, yeah, I know this is what y'all say, but can we tell you a story? Can we talk about what happened? And you can either then course correct if you need to with them. You can sometimes reset expectations or talk through what didn't go well, or you can reevaluate the strategy if it's to that level. So those regular touch points with people to make sure that those goals and those action steps that you think are happening are really happening the way they're intended to is really important.
So help us put all of that in context. Give us an example where a real life situation, there was a safety strategy that you implemented and it helped, or because you didn't have one in place, this happened. Dave, let's start with you.
Sure. So I was previously the director of security at Urban Academic Medical Center, and I started a year after there was a murder-suicide at the location where a physician was shot and killed, and the assailant then committed suicide. And a year later, when I started, the trauma in that place was still palpable. I could still, people were still on edge a year later, which I can't blame them. And I came in there, I was brought in there to really, shift the way security was done and training and everything else. And what I did was, really built a very solid workplace violence program. We had our CNO as our champion, and she was outstanding. and got the resources to the table we needed. I mean, she was the rock star, and we couldn't have done it without her. And her support really changed the game in terms of how we approach things. So we had a great workplace violence program, threat assessment and management program we put in place, changed the entire department from contract to in-house security, 125 staff, really completely transformed the department. And a few years later, I left, and 2 months after I left, there was another shooting, not in the hospital and not really related to the hospital, but a situation where a guy had a fake gun and the police shot at him outside, and one of the bullets struck one of the hospital staff who was outside of the hospital. So it was a tragic situation. The assailant, unfortunately, succumbed to his injuries with the police afterwards, and the person who was shot actually recovered. But and I wasn't there, but I had heard from people who were there who were there for both incidents. It was night and day in terms of how people responded to the incident and how quickly they were able to resolve it, and that people still felt safe even though that incident had happened. Not that they felt completely safe, oh, everything's fine, but they said the reactions from people just knowing that the security department was so solid, that we had this great workplace violence plan and threat assessment, and everything worked smoothly and people were protected. It made a huge difference in the way they recovered from it. Again, could that incident have been prevented? I don't know. I mean, this person just showed up out of nowhere and caused this incident, but the recovery was faster. And I'm not crediting myself with this because it took so many people to create that, but it's just an example of, if you build this great program and something bad happens, people already feel safe and they know you've done a lot to protect them already. And the recovery process just becomes that much, I wouldn't say easier, but it becomes enabled and supported by this program that people know and already feel safe with. So, yeah.
Powerful story. Thank you, Dave. I do want to have Darcy have you share, but first I do want to let the attendees know we're going to also have Q&A right after this, right after Darcy responds. So if you do have a question, feel free, please, to jump in there, and let's see if we can have an interactive Q&A as well. So with that, Darcy, please.
So much of what we have in our plans revolves around having a team approach, and every plan we have has different roles assigned, and make sure that people are trained in specific ways to intervene depending on what the situation is. And when we're looking at risk in our facility, we also have the challenge and privilege of the work that we do has to still be in a therapeutic context. So when we're dealing with risky situations, we always also have in the back of our mind, but how do we still keep the environment that we're working in as therapeutic as possible for the other patients on the unit? How do we resolve situations rapidly so that we can get back to, a therapeutic milieu and the work that we're trying to do from a behavioral health perspective? So a lot of the things that we've done not only incorporate, training on how to intervene in situations, but also thinking about how do we maintain that in the background too. Overnights are particularly a challenge for that, because a lot of our systems, when you need a team approach, rely on communication. Communication's critical, but communication can also be disruptive depending on how it's done. So we have several different methods of communicating in the building, one of which includes an overhead page, which is really great. It gets everyone's attention, but not always great in the middle of the night when you've got, 100+ patients trying to sleep and you need to get a situation handled. So we also have several other communication tactics, one of which does include actually our duress alarm system. And we had a situation, our staff were super excited to tell me about it the next morning, but we had a situation where we had a patient become very disoriented and agitated. And we had to physically engage with that patient for safety. And it's the night shift. We don't want to announce on the overhead paging system that we need people to come to a specific area. So by using the duress alarm system, the staff were able to bring together the team that they needed without causing a lot of ruckus in the hospital and waking 170 some people up, then having to deal with that risk, right, and that crisis. But they were able to work as a team to de-escalate the situation and get that patient restabilized and safely back into bed.
We're that staff duress company. Thank you.
Exactly.
Yeah. That's such a great story. Thank you for sharing that. That's amazing. Thank you. And so questions, would love to hear from folks. Is there anything in particular that you want to hear more about, or anything that, I don't know, raised a flag for you, or you do it differently that you might want to share with other folks? And Rachel or Melinda, I don't see anything in Q&A, just FYI.
There's nothing in Q&A yet. Oh, we just got our first one.
How do I start implementing these changes in my workplace? I feel like, Dave, you're going to say a risk assessment, but I might be wrong.
I'm sorry, what? Can you repeat the question?
How do I start implementing these changes in my workplace?
Yeah, I mean, so first of all, it depends on where you are in your journey, let's say. You might have pieces of a program in place if you might be starting from scratch. If you're starting from scratch, the first thing I would do, and I know I'm going to sound like a broken record and everybody else, but have a conversation with your C-suite leadership and tell them what you're trying to do and ask for their support first, right? Don't start on a journey without that support, and you might not have direct access to that leadership. You might have to go through 1 or 2 layers of leadership to get there. But I think if you have a great leader that you report to, they can make that conversation happen and let you be part of it. I think that's the best situation. But making sure you have that support, and then Yasmine, doing a security and workplace violence risk assessment is the next piece to figure out. It's like a gap analysis, right? Figuring out, what do I have for policies? What do I, where are my highest risk areas? Looking at your statistics, like we talked about earlier, looking at your security incident reports and your occupational health injury reports for violence, getting all those stats together. So it is something. Security risk assessment is absolutely something. Violence risk assessment is something you can do on your own, and look, do an internal review. You can also do it, through an external security consultant to do that. But really, just get your arms around what's happening in your organization and with what frequency and where is it happening the most, and then starting to figure out what you're going to use for mitigation plans. And I'll just give you an example. One of the hospitals I worked at, when we started looking at our workplace violence program, we said, let's get all the workplace violence procedures that we have now. Just let's pull them all out of the system. We had 7 different policies related to workplace violence in one way or another. And our emergency department had written their own special workplace violence policy that nobody knew about. So sometimes you'll find things like that. It's like, okay, there's a bunch of get all that stuff together, figure out where you are, and then figure out, where you can get some quick wins here and there. And but involve a multidisciplinary team. Get your clinical folks, get your security, risk management, support staff, leadership. Get everybody together and use the collective resources that you have to really look into this and work together on it. You can build yourself a workplace violence prevention committee, mitigation committee, whatever you want to call it. Everybody calls it something different. We get a committee together and work on all this stuff together and start working in the same direction. Don't do it by yourself, and get the right support. That's what I would say.
I love that, Dave. I see a question in chat from Mary, and I'd love to ask you both this question, Darcy, because I'm sure you implement something specific with your facility, and then Dave, because you probably have seen different ways organizations have tackled it, and your story earlier of what happened with that suicide actually kind of touches on a layer of it. The question is from Mary. She asks, how do you support self-care of employees and educate the tie into workplace safety practices to support a culture of safety?
I wish I had like a magic wand answer for this one, because this is something we talk about all the time too, because time is our enemy, right? That is the hardest thing. We are all so busy, and the minute something gets resolved, we're on to the next thing. And this is definitely, more of a proactive thing to be thinking about. I think even sometimes just opening the space to talk about it wherever you have congregations of employees together, town halls, team meetings, safety huddles, those types of places, to embed a bullet point to say, let's touch base on how we're all doing. My leadership team, every week when we meet, I say, what's your number this week? On a scale of 1 to 10, where are you? Because I think it's important too that everybody around us knows where we're at. Sometimes we feed off of each other, we can support each other. If I know you're going through a really rough day, I might do something a little differently on this shift to support you, or I might keep an eye on you as a colleague and say, hey, you need to take a little walk. I got your back for now. I think embedding it again in places where we can talk without any kind of fear of, being sent to HR or anybody thinking less of us, or people having a space to just say, when these things happen, I don't feel great, or I don't know that, my team has my back or whatever. And being able to really process that together is important. I watch people's faces sometimes just relax a little bit just because we're talking about these things that are very real. I love your suggestion about designated quiet areas. I think we're also trying to do a lot more emphasis on debriefing, not just after like a crisis situation, but after anything really atypical, right? Let's just talk about real quickly what happened and do a check-in, because then we can sometimes put to bed some things that would have festered or would have distressed people further. Lots of organizations have very robust EAP programs, and I think we underutilize those a lot. And I think making sure people know that those are at their disposal and that should be encouraged to use those is really important to prevent that trauma from accumulating for people.
I love all of that. Thank you, Darcy. What about you, Dave? What would you add to that?
I think I love, in behavioral health, one of the best things I think they do is that debriefing afterwards. I think in acute care, it's not always something that gets done, but it becomes part of the process in behavioral health. Afterwards, you do that debrief and you take some notes on things and you check in with each other. But one of the things that I used to do with my security team, especially when we had if we had a very violent situation happen or something traumatic, I would just find those team members afterwards and I would just look them in the eye and say, are you okay? In a safe place where they could answer me for real. And I wouldn't stand 5 people up and in front of me and ask them that. I would just pull them aside and just look in their eyes and get an idea of because sometimes they'd be like, yeah. And I'm like, I think you need to take a walk and, get some air and, come back and talk to me in a few minutes kind of thing. But really just really checking in with your staff after something like that. And this is where your line leadership comes into play, because they're going to be the ones that be there and that are there and see it. So making sure they check in with them. And, EAP is great, but a lot of people are shy to go and use those resources. Handing them the card that says, here's the EAP if you need it. It's like, I've also had situations where, I've had there's been a violent restraint or somebody's been injured, and I'll actually call up the EAP folks and I'll say, hey, listen, we had this incident and I'd like you to come and talk to these folks as a group. I'm just gonna tell everybody, hey, EAP's coming. It's an opportunity for you to talk. You can keep your mouth shut. You can say something, but it's an opportunity. Sit down 5 people with an EAP person. Let the people talk that want to talk, and guess what? The people that don't, they might grab that person afterwards, but they at least see that that's there. So sometimes I've I haven't forced an EAP session, but made it much harder to much easier for everybody to just be part of as a group and feel kind of safe as a group. So those are a couple of things that I have done.
Last question here from Allison, that a couple upvotes here. And I think it's a really, really good question. How Allison and her team works in high stress environments. And basically she asked, how do I address or combat staff complacency? How do I keep them alert and engaged in safety? One, chaos is the norm. That's a really good question. What would you say, Darcy?
Oh, yeah, that is, and that is a challenge that only gets bigger as an organization gets bigger too. And as you get further removed, I think constant vigilance. I have a lot of thoughts. I'm going to try to drill them down. I think one, leading by example. Something as simple as, if we say no cell phones in a patient care area, don't have your cell phone out in a patient care area, right? So lead by example everywhere that you can. I also think that it's important to have a regular presence of leadership on the units and then reinforcing what you're seeing that is positive. Reinforcing when you see people engaging correctly. I think the micro learning can be critical because when you go onto a unit, if you or wherever your work, whatever your work setting is, and you see something that is amiss, using that exact opportunity to point out what could happen. It hasn't happened yet, but what could happen if something goes sideways as a result of this? I think it just helps keep people's kind of that situational awareness a little bit more alive. I think as much as you can do, real trainings that are like real to your setting too, and there's a lot of like canned trainings out there that are probably very good, but do they apply to your team's work setting? As much as you can make it truly relevant, I think that's helpful. But I think that's where I think the debriefing is also helpful if there has been some kind of an incident, because it does pull people together to talk about what happened. And sometimes if we're really honest with ourselves, we didn't follow our policies, or we got lax and we let our guard down and something bad happened. So I think reminding people that, the rules are there to protect everyone. They're there to protect patients, but they're also there to protect us, is helpful. But it is definitely, I think in healthcare, that is very much a challenge, especially when we get very comfortable in our work settings.
Fantastic. That was a great way to end this. Thank you. Thank you so much. Thank you everyone for participating and joining. Thank you, Darcy and David, for this topic, your insights. My team, Rachel and Melinda, thank you for taking care of everything and making this easy. And the attendees, of course, for joining us today. I hope you walked away with that one tangible takeaway that you can implement right away.
For more information or to speak to someone at ROAR, please contact us at sales@roarforgood.com. Thank you for attending.